Good day, we're still busy with the obstetric hemorrhages. I'm still Anna Nolte, and today we are busy with the final lesson, and that's the lesson on injuries to the genital tract, amniotic fluid embolism, sepsis, and shock. And when we refer to the injuries of the genital tract, we specifically refer to rupture of the uterus, and specifically in the patients who are doing or attempting vaginal births after a cesarean section. We're going to talk very shortly about amniotic fluid embolism because that is one of the other big reasons for shock after the birth of the baby, and that we just need to do the basic principles about that. We have briefly talked about sepsis when we did the miscarriages. We will talk a little bit more about that. Okay, so first of all, we will talk about the rupture of the uterus, and we can define that as a complete rupture or an incomplete rupture. In the case of a complete rupture, it means that the total wall of the uterus has been ruptured, and that can be with or without expulsion of the fetus in the abdominal cavity. Or we get the most often one that we see is an incomplete rupture, which means that the uterine wall has been torn, but not the perimetrium. So it's only in the uterine wall, and it can be a small tear or it can be a bigger tear. And then we get also the tear of an existing uterine scar, which are the ones that we see the most often. These complete and incomplete ones that we have talked about here on top might happen after prolonged labor, and specifically prolonged labor in the case of a multipara. In this case, where the uterine torn of or dehiscence of a uterine scar, it's usually a smaller rupture, and the fetal membranes most of the time remains intact, so the fetus is still being in the uterus and not being expelled into the peritoneal cavity like in the first case. Now, the possible causes of uterine rupture is, as we've said, a scarred uterus, where there's a previous scar in the uterus because of previous surgery into the uterus, and most specifically previous cesarean sections. Or it can be, and this is a very other important one, the misuse of oxytocin and prostaglandins in an unscarred uterus, but the dosage of the oxytocin and the prostaglandins is so high that it causes tonic contractions of the uterus and eventually rupture. High parity, what we usually get here is that the uterus, and specifically the lower segment of the uterus, is being stretched to a certain extent that it and then becomes weak in inverted commas, and we can get a rupture of that part of the uterus. In obstructed labor, that's prolonged labor, which is really going on for a long time. We know that as the prolonged labor is going on, we get that the upper part of the uterus, the fundal part of the uterus, is getting thicker and thicker, and the excessive thinning of the lower segment of the uterus and the border between this upper uterus, thick upper uterus and lower segment is what we call Bandel's ring. There's a definite separation between the upper segment and the lower segment. Or sometimes we get, especially in traumatic births and use of instruments during assisted births, we can get that there's an extension of a cervical laceration that extends up into the uterus, into the lower segment of the uterus, and obviously can cause severe bleeding. Then also trauma to the abdomen, as for example, the result of a blast injury or an accident, motor accident, can also cause, if the impulse was big enough, it can also cause trauma to the uterus. Now, the signs of the rupture of the uterus. Now, this is very difficult because this depends to a very large extent on the type of rupture and how big the rupture is. If it's a complete rupture, the signs are usually dramatic. In the case of a previous scar of the uterus, it might be very gradual and it's not that dramatic. So one needs to look out for that. Now, the abnormalities of the fetal heart is one of your first signs of uterine rupture, and that is why it is so extremely important in the case of a patient with a vaginal birth after cesarean section to put the patient on continuous CTG. As I'm saying, the first sign of distress might be your first signs that there's a rupture of the uterus. Then usually abdominal pain, two types of abdominal pain are very important. The one is a pain, and this is usually a constant pain over the previous cesarean section scar, and abdominal pain between contractions. These are extremely important, again, especially in the case of patients who are having vaginal births after previous cesarean sections. If a patient complains of lower abdominal pain between contractions, please immediately think of a rupture of the uterus. Vaginal bleeding is not a very often sign, and again, depending on where the uterus ruptures in the lowest, if it ruptures in the lower segment, your chances to see vaginal bleeding is quite big, but also the vaginal bleeding is not always in relation to the signs of shock that you see. Signs of shock, of which maternal tachycardia and obviously lower blood pressure might be as our early warning signs. Then slow progress of labor might also be a sign, although this is quite a late sign. Hematuria is quite an early sign of rupture of the uterus, and especially again in the case of previous surgery to the uterus or previous cesarean section, because the lower segment, the place where the uterine wound was or the uterine scar is very close to the bladder, and often injuries to the uterus also cause a certain degree of injury to the bladder and might cause hematuria. Then contractions might stop, and this specifically so in the complete rupture, when the uterus is completely ruptured and the fetus is being expelled in the abdomen. We get these are dramatic signs, and the signs of shock are also then dramatic. Now, this is also very important what I'm saying here regarding the signs of a rupture of the uterus. Whenever there's shock during the third stage of labor. Now, the only reasons why there should be shock during the third stage of labor is usually because of postpartum hemorrhage, because of rupture of the uterus, and we will see the other possible reason is amniotic fluid embolism. But what we are saying here is whenever shock during the third stage of labor is more severe than the type of birth or blood loss would indicate, or the woman fails to respond to the treatment given, the possibility of an incomplete rupture should be considered. So that's, for example, when the treatment that you give is the patient is bleeding and you give oxytocin and you give other oxytotics, or you try and the placenta has been already removed, but the patient is still in complete shock. So this usually might be an indication of rupture of the uterus. Then also postpartum hemorrhage might be quite a complication of incomplete rupture of a scar of the uterus, because this also sits in the lower segment of the uterus, and the patient bleeds continuously in spite of the fact that the uterus is well contracted. Management is basically the same management as what we've done now several times, is with management of a patient in shock and patient that bleeds a lot. They put up an IV, two IV lines to catheterize the patient, to treat the shock, and to do if this is a rupture has happened during the first and second stage of labor, is to do a cesarean section and get the baby out as quickly as possible, because the prognosis of the fetus is also, especially if there's a lot of bleeding, quite bad. If it's been detected in the third stage of labor and in the fourth stage of labor by seeing that the patient bleeds a lot and the uterus is contracted, then obviously a laparoscopy needs to be done. Then our next complication emergency is the amniotic fluid embolism. Now, I'm not going to go into too much depth and detail about it. It's fortunately a emergency that we don't see that often, but at least you should know about it. What happens is it is thought to occur. There's a lot of uncertainty about exactly what happens with the amniotic fluid embolism. But in some or other way, amniotic fluid enters into the maternal circulation, and that causes the emboli, and that causes the same symptoms as any big emboli. So it might happen. Now, where does it come from? What causes it to happen? It might be that the placenta, in the case of a placenta abruptio, small placenta abruptio, or even bigger placenta abruptio, that some of the amniotic fluid has go into the maternal circulation, and it often also happens during the third stage of labor with the birth of the placenta that it might happen. Now, it happens in two phases. Usually the first phase is the pulmonary vasospasms, because this embolism has gone now through to the lungs. It causes hypoxia, hypotension, pulmonary edema, and cardiovascular collapse, and this usually happens very quickly. And then the second phase is the development of a left ventricular failure with heart failure, and eventually the patient might die because of, again, coagulation problems and uncontrollable hemorrhage. Now, we usually say that the amniotic fluid embolism should be considered as a possible diagnosis in the event of maternal collapse in pregnancy, labor, or birth, wherever there are any of these obvious causes. And that's very often a sudden maternal death with a maternal collapse, or a maternal collapse with sudden maternal death in the absence of other causes is usually being associated with amniotic fluid embolism. Now, the signs are usually that of respiratory problems, because this emboli usually goes to the lungs, and then also shock and collapse. So we have respiratory cyanosis, dyspnea, respiratory arrest, cardiovascular signs like hypotension and tachycardia, shock, pale clammy skin, shivering, cardiac arrest, hemorrhage from the placental site, coagulation disorders, which we will find out later when we draw blood, and DIC. The patient might even get very restless, panic, and get convulsions at the end, and obviously there will be fetal compromise if the fetus is still in the uterus. And then our other complication that I just want to talk about quickly is also fortunately one that we don't see so often, but can happen, and that is acute inversion of the uterus. And that literally means is that the uterus is been coming outside of the uterus, and we get different degrees that you can see on these diagrams. The first degree is where the fundal part of the uterus is inverted and it reached the internal os of the cervix. The second degree is this one, where we see that the body of the corpus of the uterus is inverted into the cervix. You can start feel it here. The third degree is where the fundus protrudes into the vagina and is visible, and then the fourth degree is where there is complete uterine and vaginal inversion and the uterus sits outside. Now, the reason why I think you can see why it is such a life-threatening complication is obviously the uterus can't contract when it looks like this. So all these blood vessels where the placenta was being implanted are sitting open, and we have a massive a blood loss. And in the meanwhile, there's no way that we can get the uterus that's inverted to contract, so the patient will just keep on bleeding. Now, the causes are different. Two big things where nurses are very often being involved with, and that's mismanagement of the third stage of labor, and specifically in the case of where the uterus doesn't contract very well, or we already have uterine atony, the uterus is not contracting, and you do excessive cord traction during the Brown Andrews when you do the active management of the third stage of labor. So that's why I kept on saying your cord traction should be very gentle, and you should support the uterus to make sure that you don't pull the uterus out. The other one is where it's very important is where there is fundal pressure together with cord traction to expel the placenta, and that's where people are getting very anxious. Now, the placenta patient is bleeding. We have to get the placenta out as quickly as possible. So now instead of supporting the uterus, keeping the uterus back, there's now fundal pressure to try and get the placenta out as quickly as possible. Yeah, the same story here. And then pathologically adherent placenta, where the placenta is, like for a placenta accreta, where the placenta is been implanted into the muscle part of the uterus, we might easily, again with cord traction, pull the placenta out. In the case of a very short umbilical cord and sudden emptying of a distended uterus, that's now in the case of a multiple pregnancy or hydramnios, where we have a big uterus and suddenly the fetuses are being born quickly, or in the case of hydramnios, where the fluid gushes out and the uterus is quickly much smaller. The signs and diagnosis, as the major sign is acute, profound shock and usually hemorrhage, because as I've said, the uterus can't contract. And the blood loss is lots, within 800 to 1,800 milliliters, and it depends on how quickly the situation can be corrected. There's severe abdominal pain with this uterus being inverted. I think that's understandable. And when you on palpation of the uterus, if you now feel the abdomen, if you're doing an abdominal palpation, you might feel the indentation of the fundus, or you just feel nothing. Or in the case of a vaginal examination, you might see or feel the uterus in the cervix or in the vulva. And the management is to get this uterus as quickly as possible back to its normal place. So again, urgent medical help is summoned. We need to do the vital signs of the patient, and including the level of consciousness. As we've said, this patient lose a lot of blood immediately, so again, very shocked. High flow oxygen should be given to the patient because, as we said, she loses a lot of blood, and one should try and attempt to replace the uterus as quickly as possible. As I've said, as long as the uterus is inverted, it can't contract and it will still bleed. So, and if the replacement is delayed, if we now wait too long, the uterus becomes edematous, and then replacement is very difficult and the patient will just bleed more. So the best way to replace it is what you see in these graphical pictures here. So first of all, you put whatever you feel, the inverted uterus, you put in the palm of your hand, and in the direction towards the posterior fornix, you now push the uterus and lift it towards the direction of the umbilicus of the mother, and with steady pressure on the uterus. And then once it has been replaced, you can put your fist into the uterus to make sure that it stays there. And it might also be a good idea to lift the foot end of the bed to help gravity to reduce the traction on the uterine ligaments and the ovaries, because that is also where a lot of pain comes from. And you should keep your hand in the uterus till a firm contraction is being felt. Now, this sounds much easier than done. One can almost oversimplify it by saying that you just need to get the inverted uterus back into the abdominal cavity and to put it back into its normal position, to get it to revert it. And that is what we are trying to do. And that brings us to the end of this whole series of lessons. I hope that you have learned something and that you will be able to manage with all these different emergencies. And then now you have to complete your final quiz for this lesson.